Hello everyone, welcome to HIM 216. This is a continuation of the lecture for Chapter 5 in your textbook. Please turn to page 92. And we're going over the guidelines now that govern the selection of the principal diagnosis, one of the most important functions that you will be responsible for as a coder. And you can see that this guideline tells us that the circumstances of the inpatient admission always govern the selection of the principal diagnosis. And then we have the definition of the principal diagnosis, the condition established after study that's chiefly responsible for occasioning the admission of the patient to the hospital for care. The definition is used by hospitals to report their diagnoses, and it's also used by acute care hospitals, short-term, long-term care, psychiatric hospitals, home health agencies, rehab facilities, and nursing homes. In looking at the principal diagnosis and the coding conventions, the tabular list and the alphabetical index will take precedence over the official coding guidelines. Should you ever, and it's highly unlikely that you would ever find a conflict between the official coding guidelines and the classification system, you go with what the classification system says. I have never known that to be the case. And then, of course, we must have consistent, complete documentation in that medical record. Without it, applying these coding guidelines is very difficult, if not impossible. So you really need a complete or as close to complete medical record as you can get in order to efficiently, correctly, and effectively code a medical record. Let's look at this first example on page 92. Right lower quadrant abdominal pain due to acute appendicitis. The code for abdominal pain is R10.31, and it's due to the acute appendicitis. So the only code that we need is K35.80, which is the code for acute appendicitis. And we can put in appendicitis and then look at acute, and we'll see K35.80. And we, of course, would verify it in the tabular. Now, there are times when you have two or more interrelated conditions that both meet the definition of a principal diagnosis. And what the guidelines tell us is that either condition can be sequenced first. And that would be the case unless there's some circumstance of the admission or some therapy provided, or in the tabular or the alphabetical listing it tells you otherwise. And let's look at this first example on the top of page 93. This patient has severe dehydration and hypokalemia. They were treated with IV fluids for the dehydration and IV potassium for the hypokalemia. So the question is, what is the condition that occasioned the admission? Is it the dehydration or is it the hypokalemia? And when we look at the code for dehydration, we see that it is E86.0. When we look at the code for hypokalemia, it's E87.6. So either of these could be sequenced as the principal diagnosis, and you would be complying with the guidelines. Now, the next guideline is very similar. It says if you have two or more diagnoses that meet the definition for the principal diagnosis, that either of them could be sequenced first. And of course, you would have to make sure that the that the workup, the documentation clearly supported that either of those conditions met the definition of the principal diagnosis. In this second example on page 93, the patient was admitted with exacerbation of her COPD, chronic obstructive pulmonary disease, and decompensation of congestive heart failure. So since both of these conditions would be treated, either of these could be chosen as the principal diagnosis. So I'm going to look up if I look up heart failure, congestive, and then decompensated, I will find this code 150.9, which is heart failure unspecified. Now let me do something here. Sometimes you can put in the acronym for a diagnosis and it'll find it in the index. That is not the case with COPD. And if I put in disease, pulmonary, chronic obstructive, I will find the code J44.9, chronic obstructive pulmonary disease unspecified. So if both of those conditions equally meet the definition of the PDX, then either of them can be sequenced first. Now, if we have, it's a rare instance when we have two or more contrasting or comparative diagnosis. And this is when they are listed as either, an example is either or. They are coded as if the diagnoses were confirmed, and those diagnoses are sequenced according to the circumstances of the admission. If there's no further documentation and you cannot determine which diagnosis should be principal, then either of those diagnoses may be sequenced first. And the answer, the third example on page 93 is peptic ulcer disease versus cholecystitis. So peptic ulcer disease is often abbreviated as PUD, and we don't have that. So we're going to do disease, and then ulcer. Well, not either one of those. So we'll do ulcer and then peptic, maybe. K27.9. And of course we verify that in the tabular. Peptic ulcer, site unspecified. Unspecified as acute or chronic. And we don't have acute or chronic documented with our peptic ulcer disease. And then we have cholecystitis. And that code is K81.9. And again, we don't have acute or chronic documented, so we are just using cholecystitis unspecified. Now there are times when the original treatment plan isn't carried out, and usually you see this more often in patients who have planned surgery and then for some reason the surgery is not done. So let's say that a patient, in the example we have here, the patient was admitted for a cholecystectomy because of cholelithiasis. Our principal diagnosis here is cholelithiasis. The principal procedure, if it's done, would be a cholecystectomy. The cholecystectomy is not the principal diagnosis. That is a procedure. But the patient was having an exacerbation of congestive heart failure, so the surgery was canceled. They administered IV Lasix for the congestive heart failure. The condition determined to have occasioned the admission is the cholelithiasis. The congestive heart failure is a secondary diagnosis, but that doesn't change the principal diagnosis. It doesn't change the condition determined to have occasioned the admission, which is the cholelithiasis. So if we go to cholelithiasis, it tells us to see calculus of the gallbladder. And that code is K80.20. Calculus of the gallbladder without cholecystitis, without obstruction. So we don't have cholecystitis documented here. We don't have obstruction documented here. But if we did, it would change the code. We would be coding to that specificity. And then we have the congestive heart failure. Failure, heart, I50.9. Well, if we could do congestive, we'll find I50.9 there as well. So, in this particular example, we are going to code the cholelithiasis as the principal diagnosis. And there is no code, no procedure code, because one was not done. But I actually can look at canceled procedure in the index. I type in the term canceled procedure because of, and this procedure was canceled because we had a contraindication Z5309, and you can see some of the other options here. Left AMA, patient's decision, and then under that for due to group pressure or personal beliefs or another specified reason, or a specified reason that there's not a more specific code for. But we had a contraindication, and if we go to this particular category, this is in Chapter 21, and this category is persons encountering health services for specific procedures and treatment not carried out. And then we can see that this code is procedure and treatment not carried out because of other contraindication. Then on the bottom of page 93, complications of surgery and other medical care. If the admission is for the treatment of a complication that resulted from surgery or other medical care, that complication code is sequenced as the principal diagnosis. So that means the patient had treatment or care, discharged from the hospital, or maybe they had that as an outpatient, and the reason they're being admitted now is for treatment of that complication. If the complication is classified to T80 through T88 and the code doesn't have the specificity to describe that complication, then an additional code should be assigned. And we'll actually study this guideline more carefully when we do that specific chapter. So if we these codes T80 through T88 are in Chapter 19, and if I scroll down, I can see, let me see, you can't see it. Let me move this down. I can't move it down, I can't scroll down, I apologize. At the very bottom of this screen, the very last section, if you are looking there yourself, is complications of surgical and medical care not elsewhere classified. You can see that you have instructional notes in this chapter. You can see that we have extensive excludes notes too, and then we have our category list, which they all begin with complication following, complication of, that type of thing. If you look at this last example on page 93, patient was admitted for dehiscence of external abdominal excision. In the index, if I put dehiscence of operation wound, NEC, external operation wound, T81.31. Now, this is a really good example because you see there's no little dash there. You would think by looking at this code in the index that that's the code. But when you go to that code in the tabular, you find that that is not a complete code. If I go up and I look at the instructional notes, I'm told to use an additional code for an adverse effect if applicable. I have an excludes note 2. My 7th character is either initial, subsequent, or sequela. And when I go down and I look at my code, and I can easily find it because it's highlighted in blue, I'm going to click on my red code and I'm going to choose initial encounter. If it doesn't tell you otherwise in this book, it's an initial encounter. So my code here is T81.31XA. And that's for the dehiscence of my surgical wound. Now, this example also includes a Y code, and that is an external cause code, and that would be a complication of a surgical operation, Y83.9, and we're going to go over these external cause codes in detail. If I want to find an external cause code, I need to choose on the external cause tab. Let me see something. If I go here, if I go to Y83.9 in the tabular, I can find this code. But if I try to find an external cause code in the diagnosis alphabetical index, I won't find it. Complication, surgical procedure, T81.9. They're not here. I know that that Y code is an external cause. You see, it tells me right here, external cause of morbidity. It's in chapter 20. To find those codes, I have to choose this tab, external cause, and look for that code. And we'll go over that next semester, actually. Now, turn to the top of page 94. And this is the guideline about an uncertain diagnosis. And when we have a diagnosis that's documented as probable, possible, suspected, likely, or questionable, or still to be ruled out, or some other term that indicates uncertainty, we code it as if it existed or as if it were established. The basis for these are that there was a diagnostic workup, there may have been arrangements for future workup or observation, and the initial therapeutic approach that corresponded more closely to the established diagnosis was completed. This note is very important. This only applies to inpatient admissions to short-term, acute, long-term care, and psychiatric hospitals. It does not apply to the outpatient setting. Actually, in the outpatient setting, we cannot code these types of unknown codes. So only applies in the inpatient setting. Now, there are some exceptions to that. In this first example, possible adenovirus meningitis, we code that as though it existed. Oops, see, I'm in the external cause tab. I can't find this code there. I have to go back to diagnoses. So adenoviral meningitis A87.1. Now, there are some chapter-specific guidelines, which certainly we will go over in detail when we're studying those chapters, where we do not code possible, probable, or rule out. And these are the codes for AIDS. We only code confirmed cases of AIDS. In avian influenza and H1N1, we can only code confirmed cases of those. And another, it doesn't include it here, but because it's an external cause code, but we can't code any acts of terrorism unless they are designated as such by the FBI. And we'll study that when we get to that chapter as well. So I'm going to conclude this lecture here. And in our next lecture, we will start with admissions from an observation unit. And for this particular lecture, I want you to tell me, if I have a diagnosis of possible pneumonia, how am I going to code that? So what would my code be for possible pneumonia? And that will conclude this lecture.